Welcome to the Jianxing General Hospital Cardiology channel. This channel is coordinated by Professor Wei-Hsian Yin. He is the Vice Superintendent of the Jianxing General Hospital and Professor of Medicine at the National Yang-Ming Jiao Tong University, Taipei, Taiwan. This video highlights a case of transcatheter aortic valve replacement. This case was presented in the 2023 Taipei Valve Summit in June 9 to 11, as co-organized by Jianxing General Hospital, the Taiwan Association of Thoracic and Cardiovascular Surgery and the New Life Foundation.
Before we start, you may want to switch on the subtitles of your preferred language. On the video screen, you may switch on subtitles by clicking CC icon. To choose your subtitle language, please click Setting icon. Go to Captions. Then, select Auto Translate to open a language bar. Scroll down the bar and pick your preferred subtitles language. The subtitles now appear underneath the video screen. Now, please enjoy the video.
This case for is a bicuspid aortic valve. Please next slide.
Okay.
And, the patient came for hospital because of the short breath and the pulmonary edema, pneumonia. He has osopnea for times within these 2 months, and she has comorbidity of the psoriatic arthritis, multiple joint involvement, and she was under immunosuppressant, and he have a previous infection endocardititis for the aortic valve, and also he had the tuberculosis disease. And here we can show the echocardiography, and this is a very typical bicuspid aortic valve with moderate to severe aortic regurgitation and moderate aortic stenosis. Next. And the pressure gradient was 19/35, AVA was 1.2, and this view have severe aortic regurgitation. Next. And multi-slide CT show here the area was 517, 1 parameter was 87, and this is a true bicuspid valve, quite high, coronary high of the left and the right. Membrane septum is also long and around 15. Next. And quite good iliofemoral artery. And we also check the waist method measurement for this case is around 26. Next. So this our plan is a right radial artery for sentinel brain protection device, right common femoral artery for main device, and with a 34 millimeter Medtronic LR hub. And the two profile will be used in the left common femoral vein for the patient.
Okay, thank you for your presentation. I think because in every center they have their own strategy or approach for this kind of place.
Here, this is 34 millimeter valve. We will deploy with pacing and slowly deploy it.
Okay, put back the nose cone. Okay. Keep the wire.
Okay, 非常好
Right.
Perfect.
Thank you, Chairman. So I'm Dr. from Assam Medical Center. So I'd like to discuss how to treat this patient if this patient is our patient in Assam Medical Center. As you know, the Assam Medical Center favored subplan 3 for the even bicuspid AS after introduction. So the next issue would be the device sizing for subplan 3. Based on this Paravalvular registry, show that the annulus is the most smallest portion of even in bicuspid AS. So we mostly use the annulus sizing instead of supraannulus. We consider the supraannulus structure, but we mostly depend on the annulus sizing. So this is our oversizing device oversizing in bicuspid and tricuspid. Look at the small amount of calcification. Even though bicuspid, we apply the similar oversizing with tricuspid, but the severe calcification volume is more than 400, 1,000. We do not oversizing too much. Just the normal to this patient annular stage was the 502 square millimeters, very low aortic valve calcification. I would like to consider the two things: annular size, annular area, and calcification volume. So annulus, based on the annulus sizing, 29 is 18% oversizing. So 26 is minus 6% undersizing. So I'd like to select 29.
So for us, so for bicuspid, we usually use the Hangzhou solution. Professor Wang developed the Hangzhou solution for bicuspid AS, especially with significantly calcifying with simultaneously contrast injection in the aortic root, and then we can divide it in four groups. The first one is very severe waste with no regurgitation, and then we have downsizing choice of the valve. If there's waste with the regurgitation or no waste, we will not downsize of the valve just based on the annular size selection. For this patient, the patient is moderate to severe AS with the severe AR. And we can see right here, the patient is bicuspid and the almost no calcification. We can see right here. Yeah, so this is not typical case for the Hangzhou solution. So maybe for this patient in our center, we will not use. So how would I treat this case? The first one, the indication. Severe AR, moderate to severe AS, very symptomatic. So it has absolutely, we have to treat this case. So however, for this case, I think, so both of the SAVR or TAVR will be indicated.
Sizing and consideration of calcification. Next. Because for this kind of patient, the valve is almost always anchored supraannulally. Next. So in our center, we developed the comprehensive sizing method by Professor Wei. Next. We will measure supraannular size first. Next. We choose the NC surface with maximum leaflet opening and throw up and down from annulus to the tip of the leaflets to identify the narrowest part of the opening. Then we measure the long axis, which is usually the intercommissural distance. Next. And then the minimal diameter is from the leading edge of the calcium to the aortic wall. Next. Then we divide them and obtain an average number. Next. Then we make a virtual circle. Next. On this cross section to see if the valve is fit or not. Then we do conventional annular sizing. If these two measurements are disagree, we choose the smaller one because we want everything to be safe. Next, we will measure the membranous portion and see whether there is a LVOT calcification, and then determine the depth and the current takeoff. Then we determine the implantation depth. In this way, next, we think that we can have a minimum diameter for safe anchoring, not necessary to be a final size, because in case there was still paralysis after the valve anchoring, we will optimize the result by underfill or overfill the bolus. In some difficult case or borderline case, we will do balloon sizing as Zhejiang Hangzhou solution. Next, but we based on the measurement that we obtained before the procedure. Next. Then we use a stepwise deployment with first positioning and anchor the valve. Then next, if needed, we post-diet the valve from the inflow or the outflow.
We basically choose a self-expanding valve for severely calcified bicuspid valves, especially with type 1 calcified Rafa case, because it provides better sealing with safety. For this specific case, since other experts has already commented, but there's minimal calcium with AR as a dominant pathology. So I guess maybe we can apply kind of rapid pacing during the implantation to facilitate stable implantation. This should be my
very challenging case. Again, thank you for the invitation. And my talk today is going to be how to optimize the TAVR procedure when you use balloon expandable for bicuspid aortic stenosis. My name is Ivandito Kuntjoro. I'm from Singapore. And this is my disclosure. Now, we all know that performing TAVR for bicuspid aortic valve is definitely more challenging than our normal conventional TAVR. We know that the anatomy is more challenging. A lot of time, especially in the Asian population, we deal with a lot of asymmetrical calcification, very eccentric, and a lot of time the annulus is non-circular. It's very elliptical, and of course, with the presence of raphe, especially if it's calcified, we know it's going to be more challenging. And some more in the bicuspid, we're going to have to deal with a somewhat younger patient, so we have to start thinking about the future coronary access and the possible need for re-intervention, such as performing TAV in TAV in the future. And not to mention as well, a lot of this patient has associated conditions such as low coronary height, anomalous coronary origin, and dilated root. So all these things will make a procedure will be more challenging. Now, I would say there's no one perfect valve for bicuspid aortic valve. But I think, in my opinion, balloon expandable definitely have an advantage when you use it for to treat patients with bicuspid aortic valve. And I think one of the reasons is because balloon expandable have an increased radial force. So they have somewhat stronger expansion when we implant the valve. And that makes the expansion more uniform. And this is important to achieve what we think optimal circulation. Also create disadvantage for bicuspid patients, especially for patients who have LVOT calcification, severe calcification on the commissure, especially if it's in the bulky in one side, because this potentially can cause annular rupture, malposition of your valve, and also sizing. The circle method is one of the things that we also use when we measure for balloon expandable. And basically, we put the virtual valve on the annulus and go up by 3 mm radial force and smaller diameter because they start the taper. So by doing this, you're still able to achieve the optimal outcome, but you're not compromising the safety of the procedure. This is one of the cases that we did. In the first deployment, you can see we intentionally undersized the valve. There's a little bit of waste that you can see here. And then you can see the post-ballooning. We put the balloon definitely lower because this patient has STJ calcification. So around the STJ, you can see that only the shoulder part of the balloon is touching the STJ somewhat safer. And then the other thing is, by doing this is sometimes you want to flare the inner skirt of the valve as a little bit bigger, especially if the patient has
balloon expandable valve.
Most of your presentation, that because I personally prefer more using the BV than SEV for the bicuspid valve, because of the bicuspid valve has prone to have a horizontal aorta, heavy calcification, so the balloon expandable valve have more resistance to the calcification, and also large annulus. You can see that the demonstration that during the large annulus is a lot of unpredictable movement during the deployment. So I agree more about that. And personally, I will, during the deployment, the first deployment, I will undersize a lot if I make the heavy decalcification. Undersize 5%, 6% is my.
So yeah, most cases we can implant the balloon expandable and self-expandable, but I favor the balloon expandable due to predict.
But my own experience more with the sapien valve, I agree with Dr. Lin. I think I usually based on the annular size, but I really based on the amount of calcification of the leaflets or annulus, and then I would usually do undersized first, and then I would decide how much second balloon. That's how to make the decision. That way you really can avoid the annular rupture. Personally, I never had the annular rupture for the bicuspid valve. I think that's a good strategy to reduce the volume, and then you decide how much you increase.
I think today's case is a very good demonstration of using self-expanding valve for aortic regurgitation. Because as you can see, usually we don't use self-expanding or balloon expandable for aortic regurgitation because lack of calcium for anchoring. But in this particular case, because she has calcium and the fibrotic band, so we use that as an anchor.
It's my great honor to share a case which is the topic of management of paravalvular leakage after TAVR in bicuspid aortic patient. So we came across with this 72 years old male who had a history of severe calcified coronary artery disease and accept the CABG and complex PCI for several times. So you can see this is a focused view of the aortic valve in transthoracic echocardiography. This is a very severe calcified aortic valve, and also there's a huge calcium burden extend from the aortic valve into the LVOT. So the mean pressure gradient is around 40. Let's see the CD review of the focus on the aortic annulus. The average diameter is 27.9 millimeter, and the area is 618. Also, there's the huge killer nodule over the LVOT. You can see in the long axis view and the longitudinal view also. So as the patient is a type 1 bicuspid aortic valve with left and right fusion raphe. So usually the anchor point is located at the supraannulus plane. So by using the West measurement, the supraannulus measurement, intercommissural diameter is 29.5, and the leading edge from the aortic wall to the calcified raphe is 19.3. So the average diameter is 24.4. In this West comprehensive sizing master, the goal is to identify the minimal safe anchoring diameter. So we choose 26 millimeter, and the valve is, although the function is relatively well, the mean pressure gradient is only 2, and peak pressure gradient is only 6 millimeter mercury. So at that time, we stopped the procedure and we accept the paravalvular leakage and try to use medical treatment to control his symptoms. However, 7 months after the procedure, he suffered from several episodes of hospitalization for heart failure. You can see the follow-up CT scan is formed like a diamond ring shape. The diamond is the calcium fusion raphe, and the ring is our valve. So it's pretend to be an oval shape, and there's 2 paravalvular leakage. On the short axis view, you can see it's on the 2 o'clock. Paravalvular leakage is not uncommon in aortic stenosis patient, especially for the calcified raphe for the bicuspid aortic valve patient is more prominent. I think this is an independent negative prognostic factor which has negative clinical consequences to affect our patients. So since TAVR has been expanded to a lower risk patient groups, this is necessary, and we need to move our attention to the paravalvular leakage management. Also, the valve development technology is also essential to improve the favorable risk-benefit rate.
So seven months later, for the index procedure, the patient developed heart failure. So Based on your image, I recognize that the paravalvular leakage was kind of worsened over the month. So was there any recoil of this balloon expandable valve due to the very heavily calcified native valve?
I think in this patient, the valve is undersizing, and maybe there's some recoil after the valve deployment.
Afternoon, everyone. Thank you for invitation to bring me to Taipei. Just alive, as you have mentioned. So I have the interesting case initial as planned for case discussion, but so this is the case with bicuspid Taiwan with calcified raphe and LV, severe LV dysfunction. So it's an 85 years old female with the past history of diabetes, hypertension, and CA sigmoid. She has been presented with acute decompensated heart failure. This is her pre-assessment of the CTA with annulus area of 446 and coronary is a borderline low of 9.8 on the left and 11 on so I think this is bicommissural left and right calf calcified raphe with the type 1 silver. The concern is aortic valve area, aortic valve calciums of 3800 with calcified raphe. Low ejection fraction, gradient is about 70 with borderline left low coronary height and have some calcified nodule in the LVOT. Anyone want to discuss up to this point if you want to manage, or I should maybe move on to present?
Okay, maybe we can have a discussion.
I think I probably also agree that I probably will use a balloon expandable in this case. One of the concerns that I have is if you look at the hockey puck view, there's the calcium bridge on the non-cast. The only concern I have is that although there's a raphe there, my concern is where the valve is going to move towards your left cast. And you mentioned that the left coronary height is a little bit low.
Right.
So that's the concern that I have.
Dear peers, if you have any interesting or even controversial comments, please feel free to post them or email them to me at kol@p2pmd.net. I will reply to these comments in a special Q&A video next month.
Please take 10 seconds to learn how you can be more than just a spectator at P2P. Right now, tens of thousands of healthcare professionals are actually watching this video. You may take this opportunity to post your own cases, best practices, and research data in the comment box underneath the video. So, don't miss out on this chance to make your work known to global peers.
If you have any captivating insights that you would like to share with your peers, please email your thoughts to kol@p2pmd.net. Here at P2P, we welcome collaboration with the brightest minds on the planet.